Good morning. We have the speaker, Dr. Milap, who is MD Internal Medicine, Fellow National Board Critical Care Medicine and EDIC Critical Care Medicine, and he is working at Synergy Super Specialty Hospital, Rajkot. Over to you, Dr. Milap.
Very good morning to all respected seniors and my dear friends. It is always privilege to be a speaker in Surat because this is my hometown, and today is a very special day because I am speaking in front of my teachers, Dr. K.N. Bhatt sir, Dr. Ramesh Suti sir and Dr. Samit Trivedi sir. So without wasting much time, we'll just start with the toxicology update. Today my main focus will be on the extracorporeal therapies in poisoning, including hemoperfusion, hemodialysis, plasma exchange, what is the role in poisoning. We'll touch upon the ECMO, both VA and VV ECMO. We'll discuss a few slides on lipid sink therapy. We'll see the new toxidome and what is newer diagnostic modalities and what is the role of AI in toxicology. So extracorporeal therapy use depends upon the physical and chemical properties of poison and the pharmacokinetics and pharmacodynamics of the poison. Three main types of extracorporeal therapy is used in poisoning. One is hemodialysis, the principle we all know, diffusion, convection and ultrafiltration. In poisoning, the convection will help. Hemoperfusion is very useful. They have got this adsorbent material. The adsorbent materials are lined on the column and the blood will flow through this column. The main is charcoal and resins, but there are some newer adsorbent material also. We'll see in the later slide. The main principle is this toxin will attach to this adsorbent with the van der Waals force. This van der Waals force are the physical force and they are the loose force. What is the importance of this van der Waals force? We'll come to know in few slides. And plasma exchange is also very helpful for the removal of the toxin and immune complex. So if the toxin is lipid soluble, moderately protein bound, 80 to 85%, so it has got high volume of distribution like paraquat and OP poisoning. So in this, early hemoperfusion is the answer. Water soluble, low protein bound, less than 80%, so it has got low volume of distribution like alcohol, beta blocker, atenolol and lithium. So they can be removed with the help of dialysis. And if the toxin is very highly protein bound, more than 85%, so it has got very low volume of distribution like calcium channel blocker and yellow phosphorus, they can be removed with the help of plasmapheresis. Same thing has been shown in this chart. So the main crux of the talk would be hemoperfusion is paraquat poisoning. Paraquat poison is the most common poison for which hemoperfusion has been studied. The lethal dose is 5 to 15 ml of 20% aqueous solution. Mechanism of injury, we all know that it is oxidative stress. It will damage to kidney, liver and the lung. But the damage to kidney and liver is reversible. Damage to lung is not at all reversible because it causes pulmonary fibrosis. Paraquat is very rapidly absorbed from the GI tract. The volume of distribution is high. The main concentration will be picked in the lungs because it is actively taken up by the lungs, type 1 and type 2 alveolar cells. So in 15 hours it will peak in the lung. In 12 to 24 hours it gets excreted from the kidney in the unchanged form. But in severe poisoning there will be a renal failure because of the proximal tubular damage. So each 5% drop in the renal failure, renal function will increase the 50-fold concentration in the plasma. And of the plasma concentration, there will be 20-fold rise in the lung concentration. So 12 કલાકમાં તો બધી વાર્તા પૂરી થઈ જાય જો severe poisoning હોય તો. So whatever you have to do very, very early. After 12 hours, the concentration in the lung will be very, very high. There will be alveolitis, and later on patient will develop pulmonary fibrosis. So, you have to do within 6 hours and not later than 12 hours. There is a semi-quantitative test for paraquat. It is called sodium dithionate test. You have to take 10 ml of urine, 2 gram of soda bicarbonate and 1 gram of this salt, and you have to view against white background. The dark blue color indicates very high level of paraquat. This is one sample from our patient, and the pale one is after the 7 cycles of hemoperfusion. So what are the evidence? Most of the evidence related to paraquat has come from the country like China and Taiwan. Most of the studies are retrospective observational study and few prospective observational study. No randomized control trial. You can see this is very large study, 487 patient. What they have do? They have made 5 group. One is the control group, so they have not done hemoperfusion in this. There is one hemoperfusion group, only 2 cycles of hemoperfusion done as per the patient's choice. One is CVVH group. They have done only CVVH in this. One is strengthened hemoperfusion group. What is strengthened hemoperfusion? They have done back-to-back 5 cycles of hemoperfusion, each cycle lasting for 2 hours. And over 10 hours, they have done the 5 cycles. And the last is the strengthened hemoperfusion. And immediately after that, they have started CVVH. So you can see the lowest mortality is in this group, 24%. So, strengthened hemoperfusion plus CVVH. Another study from China, 10 patients. They have compared hemodialysis plus CVVH with the hemoperfusion. They have done 6 cycles of hemoperfusion and then hemodialysis or CVVH. So, mortality was less with hemoperfusion and CVVH group. You can see in this Kaplan-Meier curve. Another study, 84 patients. Here they have done the goal-oriented hemoperfusion. What is goal-oriented hemoperfusion? They continue to do hemoperfusion till the urine paraquat level is negative. So, in patient who has taken less than 50 ml of poison, the mortality benefit was there in goal-oriented group. But if in the case of severe poison, who has taken more than 50 ml of paraquat, the early hemoperfusion also is not making any difference. 2 studies from India, one is from Vijayawada, another retrospective study, 75 patients. They have shown that if you do hemoperfusion in less than 6 hours, 43% chances of survival. If you do after 6 hours, nil chance of survival. Another small study from Belgavi, but recent one, 2025, 12 patients only, but early hemoperfusion is associated with 75% survival. So what should be the regimen? Must be done within 6 hours, that is sure. More than 1 cycle, that is also sure. Best is goal-oriented hemoperfusion, means till the urine paraquat test is negative, you continue to do back-to-back hemoperfusion. Or you do strengthened hemoperfusion, you do the 5 cycles of hemoperfusion at a stretch. Another popular regimen is 3-2-1-1, as suggested by this Jeffron company who is making the filter HA230, but there is no evidence for that. So what should be the duration? આપણે ઇન્ડિયન મેન્ટાલિટી એમાં પાછી ગુજરાતી મેન્ટાલિટી કે ફિલ્ટર છે 4 કલાકનું લખ્યું છે, થોડુંક વધારે ચલાવો ને વધારે ટોક્સિન નિકળશે, 6 કલાક 8 કલાક લગીને ચલાવીએ, પણ નો, 4 કલાકમાં તો એના જે એબ્ઝોર્બન્ટ મટીરિયલ હોય એ સેચ્યુરેટ થઈ જાય છે, એન્ડ ધેટ લૂઝ વાન der Waals force એ પાછો લૂઝ થવા માંડે અને ટોક્સિન will rise again into the blood. So you do for the recommended time which is given by the company, 2 to 4 hours means 2 to 4 hours. Don't extend the duration of hemoperfusion filter. If you want to do, you take another filter. Additional therapy, activated charcoal, early HD and CRRT as we have seen, immunomodulator therapy in the form of pulse methylprednisolone, oral cyclophosphamide, antioxidant like vitamin C, vitamin E and acetylcysteine. It has got this supportive role. Factors associated with high mortality, very high paraquat level, 5,000 nanogram per ml, or dark blue color in urine paraquat test is associated with very high mortality. Delayed presentation associated with high mortality, and if you do hemoperfusion after 12 hours, it is also associated with very high mortality. This is the first generation charcoal filter, and second is the resin filter. Charcoal filter was associated with hemolysis, thrombocytopenia. Nowadays it is not available also, and HA230 is freely available. It is more biocompatible and less hemolysis and thrombocytopenia. This is the slide from the Jeffron company. So to conclude, role of hemoperfusion in paraquat, early hemoperfusion within 6 hours of ingestion for the best results. Important for the doctors who are practicing in the periphery, because they are the first point of contact. So they have to do this hemoperfusion. You can do with your simple hemodialysis machine also. 2 to 3 cycles back to back, no gap. Urine paraquat level guided hemoperfusion is the best. Early CRRT or hemodialysis after hemoperfusion, as it has shown to improve survival. And don't forget immunotherapy and antioxidant. If patient has taken very large amount, it is associated with almost 100% mortality. Another poison for which hemoperfusion has come in a big way is the organophosphorus poisoning. ઓર્ગેનોફોસ્ફરસ પોઈઝનિંગમાં આપણને ખ્યાલ છે કે મોટાભાગના પેશન્ટ સર્વાઈવ થઈ જતા હોય છે, થોડો ટાઈમ લાગતો હોય, 5 દિવસ 15 દિવસ, 3 weeks, 4 weeks, પણ મોસ્ટલી પેશન્ટ સર્વાઈવ થઈ જાય. But if you do the early hemoperfusion in this patient, there are very large study. This is a prospective study, 260 patient. Another study, randomized controlled trial from the South Africa, 40 patients. Another study, 136 patient. Conclusion of all the study is hemoperfusion reduce the total atropine dose, so it will reduce the atropine toxicity. It shortens the cholinesterase recovery time. Almost 40% reduction in the length of stay and ventilatory day. That is very huge, especially in the severe cases. In one of the study, they have shown that if patient is requiring more than 7 days of ventilatory support, it will reduce your ventilatory days by 40%. So that is very, very important. It will reduce the incidence of intermediate syndrome. It will reduce the mortality. Suggested regime is on the first day you do 2, then 1 and 1. Other use of hemoperfusion, it is very helpful in snake bites and bee stings and pufferfish bite. Poisoning by the poisonous plants and seeds, detoxification in drug addicts, and drug overdose like methotrexate toxicity. What is the role of hemodialysis and CRRT? It is well documented in methanol poisoning, beta blocker overdose, and many other water-soluble toxins. You have to keep in mind the pharmacokinetic, pharmacodynamics, and physical property of the poison. Depending upon that, you can decide whether to do HD, CRRT or hemoperfusion. Role of cytosol, yeah, it has got some role in severe serotonin syndrome, and cytosol is very important for the patient who are on ECMO for the toxic myocarditis as a support system to reduce the organ failure secondary to the cytokine excess. Plasmapheresis. Yesterday only we and Dr. Jay Kothari were discussing the role of plasmapheresis in toxicology. Hematotoxic snake bite, which is refractory to the antivenom, refractory DIC, or it is called venom-induced consumptive coagulopathy. In that case, you can do the plasmapheresis, you can remove the toxin. Saw-scaled viper, the antivenom is not there in that common antivenom. So in that case, it is very, very useful. You can use in the dabigatran overdose. If the idrusuzumab is not available, it will reduce the concentration by 50 to 60%. And the toxic mushroom poisoning also, it is helpful. ECMO, we all know that it is very helpful in the toxic myocarditis. But in very, very severe cases, even after the 4 to 5 days of ECMO, the LV is not improving. In that case, if you do the L eventing, it will reduce the load on the LV and it will give you some more time. And the glucose insulin drip you should be using along with the ECMO. It is shown to reduce mortality in severe cases. Early CRRT with auxiliaries or cytosob is helpful in cell pause on ECMO with multi-organ failure. And the most important is infection control and general nursing care of ECMO patient. We have seen that nowadays in small centers also ECMO is being done. But that level of nursing care is not there. That level of cannula care is not there. So we have seen many patients who has improved LV, but they are dying of the infection and the complication of the ECMO. VV ECMO is very important for the toxic inhalation gas injury related acute lung injury. One of our friend, Dr. Vishal Saldara, he has recently done 4 to 5 cases of hydrogen sulfide inhalation. Lipid sink therapy is useful for the lipid soluble drug overdose, local anesthetic drug overdose. It will remove the toxin from the heart and the brain, and it will transfer that to kidney and liver where it will be metabolized. So it is a standard of care for the last. Last is the local anesthetic systemic toxicity and other lipid soluble cardiotoxic drug. Newer toxidome, 5 classic toxidome, and there are so many newer toxidome. Just I am listing them. What is the role of AI? AI will be helpful for the decision support system, for the image recognition, but AI cannot replace the intensivist or a medical person. Newer diagnostic tool is high resolution mass spectrometry. It is helpful for the screening and identification of any toxin and substance. It is available at Ahmedabad with our toxicologist friend, Dr. Tejas Prajapati. So to conclude, early hemoperfusion is useful in various poisoning, especially in paraquat and severe OP poisoning. Dialysis, especially CRRT with newer filter, is useful in various water-soluble poison and as an adjunct to ECMO and hemoperfusion. ECMO is lifesaver in toxic myocarditis and toxic gas inhalation induced lung injury. And lipid emulsion therapy is well established in local anesthetics, drug toxicity, severe beta blocker and severe calcium channel blocker overdose. Thank you.
Can I ask one question, Dr. Milap?
Yes, sir.
You did mention about this Chinese literature, Turkish literature and the Saudi Arabian journals, right? In which conditions, or what about some comments about the guidelines of the Indian Society of Clinical Toxicology?
Yeah.
Do you use them in your practice, and particularly which guidelines are better?
I am not aware of any Indian guidelines for the extracorporeal therapy in toxicology. The most of the literature is coming from the China and Taiwan. And it is not, this paraquat is banned in Europe and USA. So they are not getting this type of poisoning. So we are not getting any high quality research on this.
Thank you. Thank you.
Thank you.
Thank you, Dr. Mashru, for such a wonderful and fruitful presentation.